right now, in the practical sense, that's a really important question. And hopefully there'll be a trial in the cooperative groups that looks at that. One of the problems with that has been that what drugs are going to make up the sequence. You know, that's been changing. It was ipilimumab and vemurafenib, but now it's PD-1 and maybe ipilimumab versus dabrafenib and trametinib. So that's difficult. I think most of us right now believes that some patients will probably have a better chance at long-term durable response if they take immune therapy first. Now that's a tricky statement, and it's a tricky thing to really know. I think we sort of make a judgment when we see the patient. Well, this is indolent disease, we'll have plenty of time, we'll be able to treat them later. That's not always the case, and frankly, some of those patients, I think, are harmed by doing that. But we sort of make a guess. The other thing that we've seen, and I think this really needs a trial, is that some of the patients who get targeted therapy, small molecules, when they relapse, some of them relapse with fairly aggressive disease. And at that time point, it can be very difficult to give immune therapy. So there is a belief, and it's a belief, and sort of anecdotal, with some data that in certain groups of patients, it would be better to give immune therapy first. That's not a patient who has rapidly growing disease or high LDH or poor performance status who needs a response. This is the patient who has a performance status of 0 and feels great and has small volume disease.